the question that comes now, I think we have some consensus here that we're going to use this regimen and move forward. But what's the next step here? How are we going to do an even better job for patients? And is there a role for these drugs in patients that either are not getting, I'll ask you first, not getting concurrent chemorads, but let's say because of a side effect, a patient with severe neuropathy, for example,
right.
Not getting a chemotherapy regimen, or because of a poor functional status, they would
right.
only get radiation.
Well, I'd love to see some trials being done looking at the consolidation durvalumab after some sort of radiation course for people who are medically impaired. And we've only done a fair job at best doing those kind of trials because there's such heterogeneity. And some of the poor performance tests is due to burden of disease, some of it's coexisting conditions, and there are multiple. But I'd love to see a trial where we look at adjuvant durva with either radiation alone or a very attenuated course of concurrent chemotherapy with radiation, because we've made no real progress with those patients. The main progress I've seen is that radiation oncologists have demonstrated for such patients a more hypofractionated regimen of radiation is doable with good symptom management, not too much toxicity. So doing hypofractionated radiation, some sort of chemo and adjuvant durva, I'd love to see that tested.
But in that these patients ultimately face metastatic disease as the biggest risk to their life and health, wouldn't it make more sense to give the durvalumab or other immune checkpoint blockers with the radiation, even if those patients don't get chemo?
So that's and that's being looked at in a number of studies now, institutional studies, Hoosier Oncology Group, Rutgers, a couple of the groups are looking at it. And that is bring it with the concurrent chemo radiation. One of the tough things about that, Mark, as you said, concurrent chemo radiation is tough. And is there toxicity space to add a third modality, really what we're talking about? Or
well, I'm talking about adding a second modality to those patients that aren't going to get chemo.
Agree with that.
Substituting.
Yeah. Absolutely agree with that.
Yeah, I think that's a real opportunity to move forward.
No question.
And oh, by the way, do you think that there is any side effect of the immune drugs that's enhanced by radiation, or conversely, any radiation-enhanced side effect that is worsened by the durvalumab or other checkpoint blockers?
You know, the data is still coming out in phase 1 studies. The studies I've seen do not show a dramatically worsened toxicity, but until the studies are done, I don't think we can answer that.
Okay. Jyoti, could you comment a little bit about, for those patients that are candidates for concurrent therapy, can we do a better job with the systemic therapy with the radiation?
Absolutely. I think there are long ways to go still. So again, bringing immunotherapy up during chemoradiation.
I'm sorry, but not so much the immunotherapy, but we're talking about chemo. Are all chemos the same? You think it's generic? And is that a place where we should be investigating? Is there a better chemo?
3 decades later, it's hard for me to say, yes, there's a substantial difference. There are, though, little differences, right? So it may be that certain regimens are more tolerable, and so you may be able to get full dose radiation in, patient preference, certainly, but my sense is that there's not going to be a significant difference between different chemotherapeutics. I don't think one is more of a radiation sensitizer than another. It's really about the systemic disease. As we have more patients with oncogene-driven tumors with stage 3 disease, it may be that targeting those with radiation will also be important, and intercalating TKIs with chemotherapy and radiation may still be of interest. So
when would you, that was my next question to you, when would you, let's say you found an EGFR exon 19 deletion, what would you do, actually? Let me throw that case out to you. EGFR exon 19 deletion, you knew it on day 1. What would you do?
It's stage 3 disease, and it's still curative. And
but
right now,
it's inoperable and unresectable.
still curative intent with chemoradiation. And so I would treat that patient with probably cisplatin and pemetrexed and radiation. And with the small amount of data we have, which is in this trial, 5 or 6% of patients had EGFR mutations. With that small number of patients, it looks like there's a benefit to durva. So in the absence of negative trials, I would treat that patient with durva afterwards.
Yeah, I would say that we have to be careful extrapolating from what we know in stage 4 disease to earlier stage disease. And again, I'll throw out the example in the neoadjuvant space. I don't think anybody would have expected the high rate, the rate of pathological response, double that we see with chemotherapy in people getting checkpoint blockers in the setting of neoadjuvant therapy.
And even in never smokers, so we've seen that, right?
They've seen it in never smokers, right. EGFR mutant cases. It's sort of a different ball game, so you have to be careful with that. So would you ever give an EGFR TKI to one of these persons? What about after they finish the durvalumab?
Is that 2019?
We'll
We'll have some more data by then.